Good morning and welcome on World Thrombosis Day to this very special meeting where we're going to be talking about the new National Thrombosis Survey Report. Before we start, I need to introduce myself. I'm Professor Beverley Hunt. I am Medical Director for Thrombosis UK. I'm also a practicing physician. I'm actually on call at the moment at Guy's and St Thomas's. So if I disappear, Joe will take over. Joe is the Chief Executive of Thrombosis UK. I'm also chair of the World Thrombosis Day Steering Committee, and I need to tell you that this is the 8th World Thrombosis Day. It's been a fantastic success so far. We have billions of social media impressions last year, and we hope we did a lot to increase awareness. It's also the birthday of Virchow, so it's 200 years since he was born. He is the founding father of thrombosis as we understand it, and that's why we have World Thrombosis Day on the 13th of October. We have lots going on. The World Thrombosis Day team have been doing Facebook Ask the Doctor sessions. Yesterday, we had a joint meeting with the Centre for Disease Control in Atlanta on hospital-associated VTE. And today, expect your Twitter to be overwhelmed by a Twitter chat later today about thrombosis. And of course, Thrombosis UK have been equally active. They've been going for nearly a week now. There have been about twice daily seminars on all aspects of thrombosis. And particularly exciting tomorrow, we've got all the key players in the management of vaccine-induced immune thrombocytopenia and thrombosis. That's tomorrow, Thursday morning. So now I want to turn back to the National Thrombosis Survey to remind you how important hospital-associated VTE is. We know that if we look at all the VTE that occur, the majority, 60%, are due to hospital-associated VTE. And I'm immensely proud to say that NHS England leads the world as far as delivering care and preventing hospital-associated VTE. And since 2010, we've had mandated VTE risk assessment. We have fantastic guidance from NICE, and that has meant that we have reduced the death rate due to hospital-associated VTE considerably year on year. So it's fantastic that we come from this amazing position, and we have got most of the key players here today. We need to maintain that position of absolute excellence. There's always room for improvement, and that's what this survey is about. So what we're going to do today is we have an overview from Dr. Aidan Fowler. Professor Tim Briggs is going to tell us about getting it right first time, because we have been working with them for this survey. Rupen Arya, who needs no introduction, will set the scene for the survey, and Laurel Roberts, who did a huge amount of work for the survey, will walk us through it. And then we have time for a panel discussion with lots of luminaries who you can see on the chat, with questions from the audience, and we will wrap up at 11:30. So I would like to introduce you to Dr. Aidan Fowler. So we're really glad to have him here today. He's National Director of Patient Safety in England and a Deputy Chief Medical Officer at the Department of Health and Social Care. He was previously Director of NHS Quality Improvement and Patient Safety and Director of the 1,000 Lives Improvement Service for NHS Wales, which has done a lot for improving management of hospital-associated VTE in Wales. And he had responsibility for quality improvement and patient safety across the Welsh NHS and was a board member of the Public Health Wales. He actually trained as an improvement advisor with the Institute for Healthcare Investment in Boston and was the improvement advisor to the Southwest Safety Patient Programme and has worked on patient safety with the West of England Academic Health Science Network. Dr. Fowler, we can't wait to hear what you have to say. Thank you.
Thank you and good morning all. And actually I was only going to speak briefly about two things in this context. So we recognise VTE as a very, very important issue within patient safety. We have developed, published in July 2019, a patient safety strategy for the first time for the NHS in England. In it, we talk about work under three headings: insight, how we learn what's going on. The infrastructure piece, the involvement piece, is making a system for safety. I think too often we've done work, and VTE is an example, and I started some of my safety work in the southwest of England, where we did a large piece of work on VTE reduction. And I think sometimes it went into a system that was moving, and there was turnover of people's involvement, and it somehow gets lost. So we wanted to create a structure that things could stick to, and we wanted to involve patients more, and we created a whole series of things, including a patient safety syllabus and patient safety specialists, to try and get greater traction on some of these otherwise intractable problems. And the third part of what we do is improvement work around safety. So that's the elements of the strategy. Now, what our insight work tells us is that VTE remains a big problem. It's responsible for thousands of deaths each year, and some of those, clearly a lot of those, are potentially avoidable. One of the other things we've done is developed what we call a patient safety committee. And oh, sorry, I've got music in the background. I'm going to turn that off. My calming music. And that committee is designed as a way of joining up our thinking on patient safety across a number of arm's length bodies, whether that's MHRA, estates, DHSC, and so on. So it has membership, senior membership, across all those organisations of decision makers. And as we've established it, what we wanted to do was pick some of the big, what we sometimes refer to as giants of patient safety, and make further progress with them. And we went to all our members and said, what is the first issue we're going to deal with? And we chose VTE as that. Now, that's in the early stage, it's in the development stages. But what we've done is we've gone to all those organisations and said, what steps can you take as a contribution to reducing the level of VTE in our system? And we are taking views from all of those in order to then design a programme. And actually, I've been really pleased with the response to that, because there are parts of our system where you thought people may say, well, we don't play any part in this. But actually, everyone has come forward with practical steps that can be taken to work on this, whether that's NHS estates, who, not surprisingly, talk about design of hospitals, mobility, how we encourage mobility, and so on. PHE, who talk about the pre-hospital, the societal elements, the health issues that lead to higher rates of VT, and so on, how we address those, as well as thinking about the in-hospital elements of risk assessment and prescribing and so on. So from that, we aim to form a programme that goes back at VT and addresses it. The second thing I just wanted to cover in this meeting was to talk about recovery. So you will all recognise that there is now a long waiting list in the NHS for procedures particularly, and we recognise that in increasing the amount of work, and particularly doing it in different environments, that will increase the risk of VTE potentially. One, because of the volume risk. If you do more operations, you will see more of it. But two, because when people work in different environments and different ways, as they will inevitably have to do, there is that risk that elements of protection from VTE will be dropped. So we've also developed a recovery program, and we're working on the funding for that, which will see us take advantage of the network of patient safety specialists. We now have 700 named across the system, and we will have a central program to support them in looking at various elements of safety around recovery, but particularly looking at VTE and how we reduce the risk that we might otherwise see of increased numbers around that. So I think those are two elements I just wanted to talk about that we're doing, but I mean, I think it's important on this day of all days to point out that we have chosen VTE as our first big giant of safety to go back at as a whole system, and there will be more coming on that. So thank you for letting me speak today.
Thank you very much. It's great to have you here. I hope you can stay on and take some of the questions later. That would be really fantastic. I know I've already got some for you, but let's move on. The next person I'd like to introduce is Professor Tim Briggs, CBE, because he's been key in this particular survey, as have his Getting It Right First Time team. So Tim was appointed to the Royal National Orthopaedic Hospital as a consultant in 1992, and his specialist interest is orthopaedic oncology, as well as surgery to the hip and knee. He was appointed as National Director for Clinical Quality and Efficiency for the NHS in September 2015, and asked to lead and roll out this very exciting problem of getting it right first time methodology. And he developed it in orthopedics across all surgical and medical specialities within the network. In January 2019, he was made National Director of Clinical Improvement for the NHS. And in recognition of all his fantastic work, he was made a Commander of the Most Excellent Order of the British Empire in the 2018 New Year's Honours List for his services to the surgical profession. So Tim, we'd love to have you say a few words. Thank you so much for coming today.
So Beverley, thank you for that very kind, I have to say, introduction. And just to let you know that I work very closely with Aidan because patient safety is also, I hope, what the GIRFT programme also is what it tries to exemplar as well. So I see myself and Aidan working very closely together. So the Getting It Right First Time programme really started because of what I was seeing in practice. I had a tertiary referral practice at the Royal National Orthopaedic Hospital and was seeing patients that either people were found too difficult to manage or had been managed in possibly in an inappropriate way or developed a complication, which if things had done a bit better, then they could have been avoided, with resulting in a lot of morbidity for patients. And I felt that we could do things better. And so with a grant from the Secretary of State, who has been Jeremy Hunt, who has always been very supportive of the GIRFT programme, we were able to take the methodology, which was a clinically led programme using data, to individual trusts to meet the clinicians and the managers to talk about what they were doing well, what they could improve and what they needed to change. And we had some very difficult conversations initially with people buying into the programme, but also individuals who didn't really want to change, especially around the low volume procedures. However, the programme in orthopaedics delivered significant gains for patients, squeezed out unwarranted variations, squeezed out complications, and gave patients a better outcome, which meant that overall for the taxpayer, it was best value. We were then asked to take that model and then roll it out into all the surgical specialties and then into the medical specialties. And I think people have been surprised, really, because everybody said that, all right, the data's there in orthopedics, but the data isn't there in the other surgical specialties. It's not there in the medical specialties. But do you know what? It is. And so far, the GIRFT programme has now published 31 national reports. We published 18 recently, which is a lot of the medical reports, got another 9 to go, and they should be published by the end of the year. And the recommendations and the feedback we've had from those national reports has been of one of overall positivity. I don't think there's been any negativity about that. And the great thing about it is we've been able to bring together all the colleges, specialist societies around this, using this methodology and data, because it's non-confrontational, it's clinically led, about driving real change. And leading on from that, we've been delighted to be able to collaborate with other groups where they've got a burning issue. And I think this is a really, really good example about how we can support using the same GIRFT methodology, specialties who have a real issue about VTE, how we can help, how we can use our methodology to help this, this group and publish this report today, which I think has some fantastic recommendations. And for me, it's all about the clinicians. The clinicians have to be respected to do this work. They have to be driven to do it, and we can help provide the analytics and data. So I would like to congratulate on this piece of work, of course, Beverley, Rupen and Lara, and also the support they've had from all the colleges, specialist societies. And that's why I wanted to support the recommendations in this report. And I know that's why Aidan's here as well. So I'd like to congratulate you all on a fantastic piece of work, which I think will improve outcomes for patients, reduce complications, and as we know, as we move into a difficult time, provide best value. So thank you, Beverley.
That's great, thank you. So now we're going to move on to the report. I'm going to call on Rupen to set the scene for the thrombosis survey. Rupen is my peer here at King's College. We're both professors of thrombosis and haemostasis here. He's up the road at King's College. I'm at Guy's and St Thomas's. But he is also the clinical lead for the National VTE Prevention Programme at NHS England. And he's director of the National VTE Exemplar Centre Network, which has overseen establishing more than 30 VTE Exemplar centres. He's got many roles internally within the haematology department. He's lead clinician and deputy clinical director in haematological medicine at King's College Hospital. And he has lots of research interest in venous thromboembolism, anticoagulation, thrombophilia in women's health, and the use of global coagulation assays to define bleeding and prothrombotic states. Rupen, the stage is yours.
Thanks, Beverley. And thank you to Thrombosis UK as well for inviting me to join you today. It's my task to help set the scene for the National Thrombosis Survey recommendations. And indeed, it's a pleasure to be in the company of like-minded folk who are equally committed to improving quality of care and patient safety. And really, it's been a privilege to be part of the National VTE Prevention Program over the years. Going down memory lane, 2005 was a Health Select Committee report. The Exemplar network was launched in 2007. And then the National VTE Prevention Program under Professor Sir Bruce Keogh's oversight in 2010. And we knew at the outset what a good VTE prevention pathway should look like, whether the risk assessment and then informing the patients about the risk and giving appropriate prophylaxis and monitoring both the process as well as the outcomes. And we are indeed fortunate to have benefited from some of the real trailblazing quality improvement initiatives within the NHS. VTE risk assessment was one of the first four sequence. Equally, the key elements of VTE prevention are included in the National Standard Contract. We created a national outcome indicator around post-discharge VTE deaths. And most recently, really, I'm very grateful to Professor Tim Briggs and his team for allowing us to work together on this very important initiative with his excellent team. So I think a key aspect of all of this work has been raising awareness, whether it's amongst patients or the public, healthcare staff, and really all of those interested in quality improvement and safety within our trusts. And I think, as Beverley said at the outset, the program has undoubtedly been a big success. And now I'm proud to say, as envisaged at the outset, VTE prevention is embedded in standard practice within healthcare in England, and that risk assessment targets are pretty consistently met. And many, but not all trusts have got structures around VTE prevention. Globally, this initiative again is hailed as an exemplar and emulated in healthcare systems around the world. Nearer home, we have a network of 36 exemplar centers dedicated to promoting and developing best practice in VTE prevention through a multidisciplinary and collaborative approach. We have a website that hosts all the resources, along with a very, very successful e-training module we have produced along with Health Education England and e-learning for healthcare. I think most importantly, we have demonstrated for the first time anywhere in the world that a systematic approach to VTE prevention helps improve patient outcomes. With the most recent data, as Lara will also describe, we have seen a 15 to 20% reduction in post-discharge VTE deaths, which to my mind is a huge achievement and has come about through a collaboration between the NHS bodies, whether it's NHS England or Improvement, Thrombosis UK, the All-Party Parliamentary Thrombosis Group, industry partners, and I think probably most important of all, many of you who have joined us today, who are the champions within the NHS, who've done this because you believed that it's the right thing to do for our patients. So just moving on in preparation for what Lara is going to say next, what comes next? How can we build on this success? How can we ensure that patients continue to benefit from high quality care across healthcare? Because we are aware that it's not an ideal world. In many areas, risk assessment performance has been slipping, and we are aware that there's a significant variation in quality of care across the NHS, and really which is why GIRFT is such a powerful tool and team to help enable us to get traction in these areas, and also to help capture the data from the hospital-associated thrombosis program to identify the key themes when had occurs, to learn from these incidents, and to help improve the VTE prevention pathway and process. It has truly been a pleasure to work with Professor Briggs' team, who really are very, very effective at what they do and have helped enormously to kind of reawaken the interest in VTE, because unsurprisingly, there are many conflicting patient safety initiatives. And I was delighted to hear from Dr. Fowler that VTE, again, has been identified as a priority within patient safety. So I think the GIRFT work and the work that Aidan described really dovetails very well. So I'll stop at that point to allow Beverley to introduce Lara Roberts.
Thanks, Rupen, for setting the scene. So now we're actually going to hear about how the survey was conducted and what recommendations it produced. So Dr. Lara Roberts is a consultant haematologist in thrombosis and haemostasis at King's College Hospital in London. She qualified in Australia and relocated to the UK in 2002. And she's now clinical lead for venous thromboembolism at King's. She's got additional clinical and research interests, including post-thrombotic syndrome, anticoagulation, acquired bleeding disorders, and global coagulation assays. And of course, she was the lead writer for the National Thrombosis Survey Report. So I'm really excited that she's going to walk us through all the results. Laura, over to you.
Thank you, Beverley. I'm just going to share my screen because I have got a few slides. Bear with me. Hopefully you can see that now. So thank you very much for the introduction, and to Thrombosis UK for the invitation to speak today. As Beverley said, I'm just going to briefly talk through the aims and methods of the National Thrombosis Survey, and then focus on recommendations, specifically those aimed at hospitals. The full report's available at the link there, and I know Joe shared that previously. So these were the original aims of the Thrombosis UK, Thrombosis Survey, sorry. And there were three main areas that we wanted to focus on. The first was variation in organisational approach to VTE prevention. And the second was sort of focused on the previous NICE quality standards, looking at provision of appropriate thromboprophylaxis and patient information about VTE prevention. And the third aspect was looking at hospital-associated VTE to better understand the number of cases, where it was occurring, and the proportion and themes associated with potentially preventable events. So the survey opened in October 2019 and was originally intended to be open for 6 months. And it was used 3 surveys that were all completed online by participants. The first, as I've said, was focused on organisational aspects. The second was a prospective survey of VTE prevention practice, where hospitals were invited to submit data monthly from 4 patient groups, medical, surgical, obstetric and other patients, specifically looking at VTE prevention delivered during those patients' admission. And the final survey was focused on hospital-associated VTE. Again, this was patient-level data, and hospitals were invited to submit all cases of hospital-associated VTE over the survey period. And then, as you all know, we were struck by the COVID pandemic in February, and that had a significant impact on people's ability to contribute to the survey. And we were very fortunate to be able to extend the survey till the end of May, which also enabled us to capture some COVID-associated VTE data. And hospitals were able to continue to submit their data up until August, which I think really helped in getting the numbers of cases up. So I'm going to focus now on results from the NHS hospitals. There were also private providers and 4 centres in Wales that participated, but the rest of what I'll show is focused on the NHS. And we had a very good participation rate. 96 out of the then 144 NHS trusts took part. And I'm very grateful to everyone who did, because we wouldn't be here today without their contribution. But it's important to note this only represents 2/3 of NHS trusts, so we can't consider the findings to be representative of the NHS as a whole. So the first recommendation is that hospitals should develop or appoint a VTE prevention role. And this was based on the finding that overall only 70% of participants had a dedicated VTE prevention role in post. And as you can see here, there is some variation by region in that role being delivered. The second recommendation is that all hospitals should routinely identify hospital-associated VTE. And there was a much higher rate of hospitals participating already doing this, with just under 90% already identifying hospital-associated VTE, and a slightly lower rate in those who then investigated underlying themes. The third recommendation comes from the second survey. So this is now looking at patient-level data of just over 9,000 patients. And there is still a need to improve provision of written and verbal information regarding VTE risk. And we found that from those 9,000 patients, only 1/3 of patients were getting any written information or verbal information about their risk of VTE whilst in hospital. And clearly this is World Thrombosis Day, and we're promoting knowledge of VTE. And as Beverley's mentioned, hospital-associated VTE is a significant cause, or one of the major causes of VTE. And 2/3 of patients present after discharge. So if patients don't know what the symptoms of VTE are, they're not going to seek help in a timely manner. The fourth recommendation is to review the use of anti-embolism stockings in medical and obstetric patients. So the updated NICE guidance no longer makes a recommendation for use of anti-embolism stockings, as there's no evidence to support their efficacy. We found in the survey that about 60% of obstetric patients were still considered to have an indication for anti-embolism stockings, and 20% of medical patients found to have an indication for anti-embolism stockings. And there was, again, greater variation at a site level. So there were 16 hospitals who had obviously acted on the revised NICE guidance fairly quickly and were not offering stockings at all to obstetric patients. And there were 4 hospitals not using them for medical patients. And the fifth recommendation relates to improving delivery of anticoagulant prophylaxis. So we found that overall 88% of patients with an indication for anticoagulant prophylaxis had a prescription, but surprisingly 8% of those were missing doses without a clinical reason for doing so. And again, there's variation in this by region and even greater variation by site. There were very few hospitals with no missed doses, but there were some hospitals who reported up to 50% of patients having missed doses. The sixth recommendation is more for systems. So the NICE quality standard was published shortly before this report, unfortunately, and we've noted that it's now combined with the VTE management quality standard. And there's been a loss of the standard regarding the patient information, which is clearly still not well delivered. And we feel there is a role for a further standard regarding optimizing delivery of anticoagulant prophylaxis. So we'll be approaching NICE with our findings to ask them to consider these in future iterations. So moving on now to the hospital-associated VTE, we had data for just over 4,500 cases of hospital-associated VTE submitted, and we were able to extract HES data to calculate the rates for all the contributing hospitals, and this is rates of hospital-associated VTE, excluding day case admissions. And you can see there's huge variation. Overall, the rate was 2 per 1,000 admissions. And what I would highlight is I'd be wary of these hospitals with a low rate. I think that's unlikely to reflect better VTE prevention practice and more likely either a lack of identification or potentially a lack of ability to submit the cases given the additional clinical pressures posed with COVID. We did note that hospitals who were using radiology reports to identify hospital-associated VTE identified a greater number. So where radiology reports were included in the identification strategy, those hospitals identified a median of 50 cases compared to hospitals using other strategies where there was only a median of 20 cases. And there were some hospitals relying on adverse incident reporting alone, and they had a very low number of cases. And then we're asking hospitals to look at themes locally within the potentially preventable hospital-associated VTE. So overall, the most common underlying theme was actually thromboprophylaxis failure, where 45% of patients received optimal VTE prevention care and still developed a hospital-associated VTE. But there were 13% of patients where there was omissions in VTE prevention care, and these were considered potentially preventable. And if we look at those themes overall, there were quite a number of patients who had a lack or incorrect initial risk assessment, and a much greater proportion where there was a failure to reassess risk when their clinical condition changed. And then there were also issues with delivery and thromboprophylaxis, with it either not being prescribed too late, or with missed doses. and particularly in surgical cases, not receiving post-discharge prophylaxis when it was indicated. So we've heard a little bit about the mandatory VTE risk assessment, which was introduced back in 2010. And this is data from NHS Digital showing that the original 90% risk assessment rate was achieved very quickly. And that was later increased to 95%, which was again met very quickly and maintained. But at the last report, which was published in Q3 of 2019, there were 28% of hospitals who were not meeting that 95% target. This data collection is currently paused, but this is the only sort of national metric to drive ongoing VTE prevention practice. And we propose that there should be a buddy system provided by the NHS VTE Exemplar Centre network, where they can pair up with hospitals struggling to meet the target to try and improve their VTE prevention practice. I'm not going to go through all of the remaining recommendations just in the interest of time, but I did want to highlight one of the key things is that we'll be hoping to work again with Prof. Briggs and his team to repeat a thrombosis survey next year, but that's still under discussion. And I'd again like to thank everyone who took part in the survey. We wouldn't have this data without you. I'd like to thank Professor Aria and Professor Hunt as my co-clinical leads for their support in delivering this, and especially thank the amazing project team who were really key in delivering this and performing the analysis. And I'll stop sharing now. Thank you.
So thank you very much, Laura. That gave us a very explicit view of the outcome. I too would like to thank all the hospitals involved. So we had, this was a voluntary survey. People had to do this over and above their usual work, and they did it through the pandemic as well. And we had 96 hospitals in NHS England entering data into this national survey. It's a process that required them to spend a few hours looking at their own data. So I think that we have to give them a really big clap to say thank you very much, because this has allowed us to get a national picture of what's going on with VTE prevention. I would like to open the discussion now to the many people that we have on this call, and we'd love you to submit questions via the chat facility. I'm going to co-chair this panel discussion with Rupen, who happens to be in Mumbai, but wonderful connections today. Joining the rest of us, we have Robin Offord. Robin is Director of Clinical Pharmacy at University College Hospital, and he's been a trustee of Thrombosis UK for many years. We have Emma G. Emma is a nurse consultant in thrombosis and coagulation at King's College Hospital, and also the PRU, and lead for the National VTE Nursing and Midwifery Network. And lastly, we've got Bex Walsh. Bex is lead pharmacist for anticoagulation and thrombosis prevention at Sheffield Teaching Hospitals, and was the first pharmacist to be employed in the role of thrombosis prevention and anticoagulation in Sheffield in 2009, which is great news. Okay, so let's go ahead. Rupen, would you like to start with questions?
Perhaps before we take the questions from the larger audience, if I might invite Emma, because I think one of the strengths of VTE prevention has been the very multidisciplinary nature of the way it works. So maybe if we can invite Emma to provide a quick nursing perspective on what is the most important theme in the survey report for her from a nursing perspective. And then we'll ask Robin and Bex as well, and then open up. Emma?
Thanks, Rupen. Yeah, and I think this survey has given us some such important information. And like you quite rightly said, Rupin, I think it's just really refreshed people's interest again in VTE prevention. And we've already talked about some of the achievements over the last decade, which have been really, really significant and have definitely saved lives. However, there is still work to do. And with Lara pointing out that 30% of cats actually were attributed to potentially preventable clots where there were omissions in care, shows us that there's still work to do. I think that one of the most important things, and I've been interested in some of the chat actually that's already been going on, is about patients' information. So over a decade on, we are still to really do this and deliver this well. And I think that some of the solutions that have come up have involved putting written information in electronic discharge summaries. It enables us then to tick that box that the patient has received written information. However, somebody's pointed out on the chat that patients get inundated with written information, leaflets for various things. What we really want to know is that patients understand the signs and symptoms of VTE, because as Lara pointed out, most clots are going to happen after discharge. We know that we can't prevent all clots because thromboprophylaxis isn't 100% effective. So we need patients to be identifying symptoms and presenting early so that at least we can capture those patients and start treating them before they become very sick. So I think that, Stephanie, you're absolutely right. I think we do need to look to being a little bit more innovative in the way that we deliver patient information. Just handing a leaflet or putting a little bit of text on a piece of paper is not necessarily doing the job well. I think that what you've suggested in terms of looking for IT solutions is something that is definitely worth exploring. But I think also just making it a multidisciplinary part of the daily job is really, really effective. It's not necessarily always going to be captured on paper, but the nurse who goes to give the patient their low-methylate heparin, every single day that the patient receives that is an opportunity for the nurse to say, I'm giving you this medication. It's to prevent clot. And these are the symptoms that you might experience. You might not get those in hospital, you might get those after discharge. It takes a couple of minutes to sort of get the injection out and administer that. So there is a little bit of time there. Also for those patients that are having stockings, there's a bit of time involved in wrestling with to put the stockings onto patients. Another prime opportunity to have a discussion about VTE. But I think, like I say, it is a multidisciplinary opportunity. Pharmacists and doctors and ward rounds also in a really good position just to keep drip feeding that information so that by the time the patient goes home, they've heard about thrombosis from a few different people and have got a bit of an idea about what it is and what their roles and responsibilities are.
Yeah.
Laura, could I ask you just a little closer to your microphone, because you're just a little bit sounding like you're underwater.
I am, Beverley, did you say?
You are underwater.
No, edging closer.
Okay.
Okay, so
very good. Good point.
Can I challenge you, because NICE say we are meant to give written and verbal information, and we can't get round the written information because we do need to do it, and I fully appreciate that it's under a sea of information for the patient. Having been an inpatient at my hospital, you get an 80-page booklet when you arrive, and there's a page on VTE. Well, you're not feeling very well usually when you arrive, so it's too much. So we do need new ways of going forward. And you're absolutely right, we do need to get medical staff to talk to the patients about VTE too. Does anybody else want to address this particular subject? Okay. Shall we move on? Yeah, so looking at the recommendations, just going through them one by one. The first recommendations is that hospitals need an individual working in HAT prevention, in every hospital, not just 30%. And most of us have a thrombosis and thromboprophylaxis committee. Some are more active than others. And we need to campaign and improve the number of hospitals who have people who are dedicated to this particular role. Can we ask Dr. Aidan Fowler what he thinks about each hospital having one person dedicated to VTE prevention?
That's a really interesting question, because we, having developed patient safety specialists, have been often challenged on the fact that safety is everyone's responsibility, and if you give the role to one person, you're effectively saying it's their responsibility and not everyone else's, and the risk is that everyone else then says, well, it's not my issue to focus on. We've countered that with saying that having people dedicated to a particular area means they build up expertise, can advise, they should be senior people who can influence others, etc., etc. So I think our vision is that there should be patient safety teams, and there are a number of roles within that. So we already have medicine safety officers, medical device safety officers. By linking them to a patient safety specialist, which already exists, by the way, in a number of trusts. It's not new. We are just taking out the variation, if you like, by making everyone have one. There can be, one, that role can influence this, but two, if you then have a specialist interest in VTE, they can work with that team, because we're aiming to train all those specialists. So the patient safety syllabus will have training around it. They will be trained in a variety of elements of human factors and so on, and will develop expertise that can help with the issues that are being discussed here. How do you present information to people? You know, there's a lot of behavioural science that goes around that. I mean, I'm struck that you mentioned your 80-page document. If you buy a washing machine, it comes with an 80-page document in multiple languages, but actually there's often a single page which directs you to the important part, and there's often a single safety page that says, if nothing else, please focus on this area. So there are ways of getting people to focus on that, and I do think we under-involve patients to our cost. These are the people with the most skin in the game here, the most to gain from understanding the information. So I think we've got to get better at it. I've been shot down for suggesting airline-style safety cards for people, because the complexity theorists come out and say it's all too linear. But I do think there's more to be done on approaches to presenting information to empower patients to keep themselves safe, as well as other roles.
Do you think we should be having patients as part of our thromboprophylaxis committees within our hospitals to help us?
Well, we believe in having patients as part of every committee, and in fact, one of the stipulations in the strategy was that every quality committee must have 2 patients on it for the voice. Anything we have, including the patient safety cross-arms length body committee that I talked to you about, we have at least 2 patients on any of our committees, and indeed on the strategy committee we have 3 to increase the diversity across it. And we've been very deliberate in how we appoint those patients to give them best voice and agency, and to make sure we get representation from groups that often haven't accessed those roles in the past and from whom we don't hear. So yes, I think it is incredibly important to have the patient voice.
Thank you. Shall we move on to the next subject on the list? So hospitals are gradually thinking about not using anti-embolic stockings. So NHS England spends £65 million every year on anti-embolic stockings, and we now have the evidence from the GAP study, a UK study, that stockings have no benefit in surgical patients, and we have the CLOT study from Scotland showing that it's no benefit at all, possibly harmful in patients who have had stroke. And certainly in my hospital, we're trying to stop people using stockings and trying to get them to use intermittent pneumatic compression when the patient is immobile. And it's trying to get that funding for the stocking and make people think about intermittent pneumatic compression and how effective it is. And I think quite a lot of us need help. And I think that's one of the things that the survey is telling us, that we actually need perhaps a more active approach to this across all the hospitals. Do you have any comments on that, Dr. Fowler?
I was a colorectal surgeon back when I was what my wife would refer to as a proper doctor.
Yes.
Because she still is one. And I used pneumatic compression devices. And I remember the data were just not there to say, you know, is that in addition to stockings, isn't it? I also watched on numerous occasions patients who had their stockings sort of rolled up and tightly bound round just below their knee because they weren't fitting. So I think, and one of the things we've talked about is the need for research and understanding in the area of what the advantages and disadvantages of these devices are. So I think, and I don't speak as, I mean, you're all experts in this field, as an expert in the field, but there is there's been a gap in our understanding of use of these devices. And I think, back to your point about having specialists, once we have better data, the key thing is making sure people understand that and act on it quickly, because what tends to happen is that it gets adopted in some places and not others. And building networks of people who are active in this field means that we can share these data very quickly, because it wouldn't be a big surprise to me to find data that suggests stockings aren't as helpful as we once thought.
Okay, so there is a big meta-analysis, Cochrane review. There's also another big one showing quite clearly that intermittent pneumatic compression does reduce the risk of VTE, and its efficacy is similar to pharmacological thromboprophylaxis. It's quite powerful, whereas the stocking data shows very little evidence of benefit. NIHL have just funded GAPS 2, which will look at using stocking versus no stocking in low risk patients, just so we have totally finished looking at stockings. So maybe I think hearing what you have to say, that Thrombosis UK can perhaps do some more work and advertise the facts that intermittent pneumatic compression is beneficial and stockings probably aren't at the moment.
And Beverley, our aim with the work we're doing on VTE, which as I say is nascent, but particularly on the recovery work, is to make sure we work with people like you and particularly Rupen and so on to say, let's get the information right before we go back out at this, make sure it's up to date, make sure we are using current best knowledge, because if we're going to go reinforcing messages, they need to be the right messages.
Thanks. Rupen.
Yeah, so Beverley, the next recommendation, I think again, it falls into the pharmacy domain. So I'd welcome what Robin and Bex have to say about this very important issue about missed doses and what we can do about them. Robin, do you want to go first?
Yeah, shall I do that? So I think for me, the area of the report that was really interesting was the table relating to preventable hospital-acquired, hospital-associated VTE. And clearly this area of missed doses appears quite highly on that. I think as pharmacists in general, we consider ourselves as patient safety experts, and we've been dealing with this problem for quite some time. So the MPSA published a rapid response report in 2010 around reducing harm from omitted and delayed medicines. And there were a number of actions that they asked to be put in place as a result of that. And one of those was for all trusts to look at creating a list of critical medicines and then addressing any issues that might lead to those critical medicines not being provided for patients in a timely way in their particular organisations. Having seen a lot of those critical medicines lists, there is variation up and down the country, but they all universally contain anticoagulants. So it has been an area of focus for us for some time, but it clearly needs a bit of revised focus. I think some of the things that we could potentially look at here are around education and training. Clearly we need to go back to basics just to make sure that people understand the reasons why medicines might not be administered. So if it's simple things around medicines not being available, then clearly we can do a lot around that straight away. But there are lots of issues around clarity of prescriptions or concerns about the routes not being available, or perhaps even the patient not being available at the time that the dose was scheduled, and then a lack of clarity about whether or not those doses should be given if they're given a bit late, etc., etc. So I think there's quite a bit we could do to support decision making on wards around that. A lot of trusts have ward exemplar programs, so these are sort of accreditation programs for different wards. And I think it's critical that in those there are metrics that are associated with dose emissions for critical drugs, including anticoagulants, and for thromboprophylaxis, so that we can monitor and feedback regularly on any doses that are being missed. And then, of course, there's opportunities for regular audits, evaluation, and quality improvement projects to try and make those iterative changes over time. More recently, we've seen the advent of digital prescribing systems, health record systems. I think we need to look at what reports or alerts could help within those systems. Alerts are very difficult because an experience here has shown this, that very quickly people become fatigued with the volume of alerts they see on screen. But I do think we can generate reports in the background, either spot reports on a daily basis that then could be issued to pharmacists, just highlighting any dose emissions in their area that they may need to follow up on, but also for longer term monitoring so that we can look at all these changes over time. So I think there's still quite a few things we can look at, and another area of real interest actually is patient refusals. So why are we seeing patients actually turning down, these medicines that are effectively critical for them and their own safety? And there are lots and lots of reasons why that might be, but I think there's potential for research and also for, again, quality improvement projects to try and deal with some of those patient refusal issues and see small changes over time. I've seen some really good pieces of work on this over the years, and one of the ones that's impressed me more recently is from the Scottish Patient Safety Programme. They produced a toolkit on reducing emitting medicines, and I think there's potentially a lot we can learn from that in England and Wales. And I'd be keen to sort of call pharmacists to arms really with a campaign around trying to reduce